We'll start with Mr. Tsokos Nicholas, who's online with us. I don't know if we have him. He has joined us. Good afternoon, Mr. Tsokos. Good afternoon. So he is going to talk to us about diabetes mellitus in cystic fibrosis. Good afternoon from me. Unfortunately, I was unable to attend because I'll be in another conference in Vienna. I tried to come early, but I have COVID and I was forced to stay in Vienna. So I'll be talking about the CFRD. You know more than me the problems of cystic fibrosis, respiratory tracts, lungs, heart, etc. But we'll be talking about pancreas and the liver. So diabetes is an extrapulmonary complication and it's connected to increased mortality, morbidity. This is about the disorder of the metabolism of insulin. It is critical to know early enough the signs of the glucose metabolism. When we have early diagnosis and treatment, patients have a slower deterioration of lung function. The causes are not fully understood, though. It is a result of multifactorial conditions that constitute a combination. So we have maybe the destruction of pancreatic cells, alpha and beta cells, as well as the exocrine acinos. What are the repercussions? The diabetes has high incidence in patients with cystic fibrosis. The incidence increases through age, 2% for children, 90% for adolescents, and more than 50% in patients 30 and above. We can have multifactorial causes, functional and structural disorders that pertain to the transmembrane regulator and cystic fibrosis. This is expressed in beta cells of the pancreas. In animal models, we see that there is an inherent role to the secretion of insulin. We have mutations in CFTR gene that lead to an abnormal function of the beta cells. Now we see the membrane reducing the production of insulin from beta cells. The functional deficiency of beta cells might be due to the structural disorders. The mutation of CTFR protein intervenes in the normal operation of chlorium paths and channels, and we have pancreatic enzymes leading to autopepsy of the digestion of the pancreas. And we have a progressive fibrosis, thus reducing the mass of the inlet cells. You can see the CFTR. It affects secretion. It causes beta cell dysfunction and the volume of beta cells, thus leading to insulin insufficiency and the cystic fibrosis related diabetes. Through pancreatic insufficiency, we have a malabsorption of fat, significant incretin signaling reduction, and insulin resistance. All this schematically is here. Now, the reduced production of insulin and glucagon is a result of the total destruction of the pancreatic islets. And this is an increased risk for CFRD. Another scheme presenting the chlorium channels. Now, the clinical symptoms, polyuria and polydipsia, are not as often as frequent as in other forms of diabetes. It is impossible to maintain the correct weight regardless of the diet. We have retardation of growth and loss of weight, and we see this for years in children. BMI reduction is not necessarily seen because in the pediatric population with cystic fibrosis, the weight and the height are reduced together. So it is important for us to monitor the growth. The diagnosis, as in the rest of the diabetic patients, we have the glucose test, 75 grams, etc., or less in people with lower weight or in children. An annual check for CFRD should start at all children after the age of 10. You can see the solution, 75 grams of sugar per kilo of weight. We have blood drawn before drinking and 2 hours post. The measurement of urine glucose. We have the random sample of plasma for glucose and fructosamine, etc. All these are not recommended due to the low sensitivity. So we have glucose test. When do we have the diagnosis? When we have plasma glucose 2 hours post the administration of glucose above 200 mg per dl. Fasting glucose 126 and above. Glycosylated hemoglobin 6.5%. Random test of glucose more than 200 milligrams. The continuous glucose monitoring methods are really popular, so we've stopped talking about glucose values under 150, but we use the time in range should be on average 80 to 180. This is where we have best protection of the vessels and of the organs of diabetic patients. CFOD has similarities and differences with diabetes mellitus 1 and 2, but the pathophysiology is different. In type 1 diabetes, there's an acute onset, sudden onset. It could last some weeks. In CFOD, we have a gradual onset and it develops through years. In CFRD, there remains a small production of insulin, and cetoacidosis is quite unusual in CFRD, whereas in type 1 diabetes, it is quite frequent. So, differential diagnosis. What we have in the CFRD is that we don't have antibodies, whereas resistance to insulin in cystic fibrosis is in general transient due to acute presentation of the disease. Out of the complications of diabetes, that for diabetic patients type 1, type 2, we have diabetic retinopathy, vasculopathy, diabetic foot, etc. For CFRD patients, we have microvasculopathy, which is quite frequent, as well as the macrovascular complications that are quite rare. The treatment. We don't have many weapons in our armamentarium. Insulin, the basal or the prandial one. CFOD cannot get the best treatment without the perfect education, training, and the participation both of the patient and the family. Many times, because we do have a reduced glucose production by the liver at night, some insulins have the disadvantage. Detamid, for instance, lasts for 17 hours. We can administer it in the morning, and until 11 o'clock, the patient has insulin. After 11 o'clock, they don't have insulin, therefore they don't risk a hypoglycemia at night. Because the neoglycogenesis is reduced at night. In the past few years, the best regulation is insulin pumps, continuous administration and CGM monitoring, and they administer insulin only when needed. We are talking about rapid onset of insulin every 5 to 10 minutes measurements. This can give us the insulin that we need. In cystic fibrosis diabetes, there is a whole team that should support the patient: the diabetologist, the pulmonologist, the dietitian, because you know that we need to regulate the diet because we need protein. We have a primary healthcare playing part and a specialized nursing staff. So that's all from me. Thank you very much for your attention.
You know, diabetes is a problem for many patients, especially adults with cystic fibrosis. Can you remain in the panel for questions later or now? If questions could be raised now, please, to me. Any questions on diabetes that you would like to ask? Yes, we do have one question. Good afternoon, Mr. Tsokos. Good afternoon. Can patients with cystic fibrosis eat whatever they want, mainly sweets and candies? We adjust treatment to candies. We train them in equivalence. If you need 1 to 7, well, if there is a pump, it is okay. In children who do not have a pump, and there are many, at Sysma Noglio, which is the reference hospital, we have all children and we see them there. When they're dying for a sweet, they can. Insulin is a metabolic hormone. It regulates weight as well, so we can give it them. In patients with cystic fibrosis, is diabetes as serious as in persons who do not have cystic fibrosis? Diabetes induces microvascular complications, strokes, infarctions, limb damage. Yes, if it is long-term and if it remains unregulated for a long time, it has the same adverse effects in patients with cystic fibrosis. Mr. Tsokos, now with the new drugs, the CFTR modulators, and I am one such example, we used to do insulin prior to these drugs, but once we started taking them, we stopped insulin. What do you have to say about that? Any advice? A lot of research has done. With the act of the new drugs, viscosity is reduced, flow is increased. In cystic fibrosis, there is generation of insulin at the pancreas. The issue is to have this insulin circulating in the body. So if the viscosity is reduced, then insulin can circulate in the body. I don't know if you need insulin. No, luckily I don't need it anymore, and I wish the same to many other patients. Thank you, Mr. Tsokos. Let us free you. Thank you. Take care. Let us move on to the next speaker who came from Thessaloniki to be with us, Mrs. Anagnostou Eftichia. She's an obstetrician, gynecologist. She teaches at the Aristotle University of Thessaloniki. She's going to talk about a very nice and pleasant topic. Now, with the new drugs, we can dream about making families. She's going to talk about fertility and pregnancy in cystic fibrosis. Thank you for coming.
Καλύτερα. Οκ. Θα ήθελα να...
Let me thank in my turn for the very honorary invitation to come and celebrate your 14th anniversary. Your expression, dear chairwoman, that I am the first gynecologist that you invited in such a conference because you didn't need advice from obstetricians, but now with the new drugs, this is a very nice prospect, and this recalled feelings when I was a young doctor. I was responsible for the monitoring of high-risk pregnancy ward at the first clinic of Thessaloniki. We used to monitor women with such problems, but we knew nothing of cystic fibrosis. We had a young couple. The woman was the patient, the CF patient, and she asked whether she could become pregnant and if I could monitor her pregnancy. Uncharted waters for us, pregnancy in cystic fibrosis. The only thing we knew was the hereditary patterns. We knew that it was a gene disease with autosomal recessive succession type, and we knew the percentage of a child being born with the disease. That's all we knew. So what did I do? I mobilized my knowledge from monitoring high-risk pregnancies. Of course, the wish of the patient was very strong. She wanted to become a mother, and I had the conviction that all women have a right to motherhood under any circumstances whatsoever. I firmly believed that. So these two factors made me to accept monitoring her pregnancy in collaboration with many other disciplines, pneumologists, diabetologists, dietitians, and immunologists once she become pregnant. Now, look at the issues that a couple has to deal with, a couple who goes for consultation to a gynecologist, public or private. What they want to know is if their children will be healthy, if there is a way to do the prenatal control, what is the level of their fertility, and in case of pregnancy, what will be the evolution of this pregnancy for a female patient. As to genetic advice, first of all, now all couples who wish pregnancy are checked about the mutation of the allele, which is responsible for 60% of mutations in cystic fibrosis. And the Greek Obstetrician Society had included this in the basic prenatal check long before Social Security funds reimbursed the cost. Now they all do. Further control is not reimbursed, and we're going to see what will happen with that. So if one of the two has the disease, if we have one healthy partner and one not healthy partner, all the babies will be healthy. If one is sick and the other a carrier, then they have a 50% chance of a sick child, 50% for a healthy child. If I have two carriers, then they should know that 25% is a diseased child, 25% a healthy child, 50% a healthy but carrier child, a carrier who is healthy. So how do we check embryos? There are these ways. If the pregnancy is from in vitro fertilization, there is the pre-implantation check. If it is natural conception, then the check is by receiving a trophoblast from the beginning of pregnancy and later on with amnio. As to fertility, let us start with males. Males are healthy as to their sexual lives, no problem whatsoever. However, the problem is that the thick mucus that is there obstructs ducts, and thus males suffer from azoospermia, which is obstructive. In a few words, testicles produce spermatozoa, but due to the obstruction, the spermatozoa do not go out with the final semen, and there is this subfertility. This reduced fertility. This can be solved with testicular biopsy and in vitro fertilization. Female patients, they have a totally normal cycle. They have normal ovaries, normal menstruation, normal hormones. Their inner and outer genitalia are normal. They have a normal sexual life. The problem is the thick mucus, which prevents spermatozoa from coming into the uterus and have the fertilization. A problem that can be dealt with injection of sperm, with sperm injection. And now the most important chapter, the course of pregnancy in cystic fibrosis women. It is a high-risk pregnancy. Don't delude us. Let us not delude ourselves. The respiratory health, the condition of respiratory health at the beginning of pregnancy is crucial. And of course, we need to have the agreement of the pneumologist. Most of the drugs that women take, drugs to liquefy mucus, inhaled antibiotics, the majority of those, and pancreatic enzymes and vitamins, women go on taking them at the beginning of pregnancy, and respiratory physiotherapy is possible throughout the pregnancy. In the first trimester, the pregnancy is the same as with every other woman. There will be no different complication, and the percentage of miscarriage is not greater in the first 3 months, but in the second and the third trimester, problems start to occur. The most serious are diabetes mellitus and respiratory infections. Diabetes mellitus, as my colleague said earlier, this is a condition that, in collaboration with diabetologists and dietitians, can be dealt with. The indications are the same. If insulin has to be administered, it will be administered, and they are followed just as any other woman with diabetes in pregnancy. What about respiratory infections? We give medicines, antibiotics, but what we want is, we want the infection to be treated, but we want them to be compatible with the development of the embryos, of the fetuses. Of course, in cooperation with pneumologists and according to the antibiotic charts. Sometimes we have had to administer antibiotics about which we would have misgivings. Of course, such antibiotics have been used. The impact on the fetuses was not different from what we expected. There has been no adverse event with the embryos or fetuses. And this due to the fact that they were administered in the third trimester. So the embryos were already big. Now, as regards labor in pregnant women with cystic fibrosis, it is not different with the other women. If they need to undergo a cesarean incision, they will. If not, they won't. The big issue is to have full-term pregnancies. This is the basic wager. Breastfeeding is allowed, and the puerperal period does not aggravate the disease. And I'd like to underline here the big therapeutical value of the new drugs, the modulators, that have been approved for administering from the onset of pregnancy and also during breastfeeding. In concluding, I'd like to share with you my experience from monitoring pregnancies of this sort. I monitored 5 women with cystic fibrosis, 6 pregnancies, and there were 6 healthy babies. 5 full-term. 1 was premature, but it was a big premature baby, and it is healthy. I will admit that at first, apart from the medical problems I had to deal with, I had some problems that didn't have to do with medical parameters. There was a hesitancy in public and private bodies to manage this high-risk pregnancy because it was an unknown for them, and there was hesitancy among colleagues from other disciplines. Luckily, these problems were overcome. The wish of these women to become mothers was so big, and they had my support, moral, medical, psychological. The contribution of science has been huge with the discovery of the new drugs, the modulators. They have helped a lot. They acted as a catalyst for women to have good health, for pregnant women to come in good health. One of these women that I monitored throughout their pregnancies was 30 years old when she first came. 30 years ago, the new drugs were not around. She was in a good respiratory condition. She became pregnant through an assisted system, and she had a difficult pregnancy, many respiratory infections. However, in the end, she took a lot of drugs. I have to admit, I was very hesitant at the time. I was wondering how the embryo would go, but we didn't have another solution. That girl was born 12 years ago. She did all the tests. That's for the sake of history. She is 12 years old, very healthy, a good pupil. Also, 8 years later, the woman is taking the new drugs, and she became pregnant at the age of 39. A 39-year-old pregnancy is difficult per se without cystic fibration. She was receiving the new drug right from the start, and the only problem we had to deal with was an insulin-dependent diabetes without respiratory infections. The boy is now 3 years old. So we came to the era where we have the drugs, the prenatal control, a good monitoring of pregnancy, and interdisciplinary approach, and all these help us to make the dream of motherhood come true in cystic fibrosis. Thank you.
Miss Anagnostou, very positive, whatever you've shared with us. I think that we'll put questions right away. So you said this is the first time that we invite a gynecologist. Yes, indeed. In the past, things used to be really difficult. Just one question by me. Now, vis-a-vis the men, since many times there is a misunderstanding in male patients that they can't have children. Is this a difficult process for them? First and foremost, this is not true for everyone, this obstructive azoospermia. But if it is, it's not that difficult to handle. It is done usually in centers for artificial insemination, since indeed the spermatozoa and the testes are mature and are in very good condition, because we might have a biopsy of the testicles and being unable to find mature spermatozoa. But in cystic fibrosis male patients, these are mature. So there is a high number, and it is very easier to do artificial insemination, in vitro fertilization rather. I've talked to my colleagues, etc., in such centers, and they told me that there is no issue with the babies that come following this kind of assisted reproduction. So things go normally. What about the process? Is it difficult? Is it painful? No. No, it's not easy. It's a very small operation, a small intervention in the in vitro fertilization center, and it's done under sedation. Okay, we're talking about men, but women patients will have a longer way to go. Yes, because they don't only provide their genetic material, they have to carry the baby for a whole 40 weeks until they reach the end of the gestational period. Have you been with cases of women with low FEV1? None of the pregnancies came that simply. They were not that simple. At lower ages, etc., there were 2 women who had been randomly become pregnant. There was no one with a low FEV. So most of them had studied and considered it thoroughly. Yes, but despite that, in the era before the modulators, you know that there were many infections, respiratory infections, and we also had to handle the staff that was not familiar. I mean, I was really impressed by the way the transplant system has been organized. So the impression I got was, why in pregnancies we don't have such a vertical unit, that we do it at the private level. And at our own personal responsibility. But this is something that is private, and we should have it in a public framework. We need to have vertical units, pulmonologists, gynecologists, neonatal department, a diabetologist, to have directly this cooperation without any delay. You know, most of you know that delays are the ones that will have a price to pay. Even more so in pregnancy, when we are dealing with 2 people. It's the mother and the baby and the child. So I think that this is what needs to be done. Yes, what you're saying is really important, and you are right to highlight it, because we too should organize as an association on that. You will be more and more who are going to be pregnant. Now, one last question regarding in vitro fertilization. Since women are getting older, etc., What about in vitro fertilization? Can women undergo such a process if they suffer from cystic fibrosis? No difference whatsoever. It's as with all women, with the indications. Of course, they have a bit more indications from the point of view of cervical mucus. But personally, I've seen improvement in the quality of the mucus. As is the improvement in the nasal mucosa, then we see the improvement of the mucus in the cervix. This is how we have spontaneous pregnancies achieved. So there is no different indication vis-a-vis a woman who suffers from cystic fibrosis and is going through in vitro fertilization. There's no aggravation since the woman will be in a good respiratory status. It's as if healthy women were to undergo IVF. Of course, IVF has the option of the pre-implantation control and test, because some opt to have an IVF to have a pre-implantation test. If one is a carrier or two carriers, etc. In this case, we have the pre-implantation control. Let me explain what this is all about. When we have the union between the egg and the sperm, we get the embryo, and we send for tests to check whether this embryo suffers from cystic fibrosis, and is it a carrier or is it going to be a patient? And we get such an answer, so we know whether the embryo is healthy. And what we actually do is we transfer through the embryo transfer the healthy embryos, carriers included. Okay. Any question from the audience? Just wait to get the microphone. To what extent men with cystic fibrosis are fertile? Because I had read about 57 out of 100. Yes, this is about obstructive azoospermia. But I explained earlier. Despite that, I have 2 cases with a spontaneous pregnancy by a male patient. Really? Yes. Of course, the person most competent to talk about that is a urologist. But the way I see it, and the way I see the impact of modulators on the mucus, I suppose that they have a similar effect on sperm fluids. So therefore, the subfertility rates will drop. Without the modulators, yeah, I could think it's somewhere close to 97%. Despite that, let me tell you something. This is a very easy process, believe me. Is it under sedation? Yes, yes. It's a pity for one to stay behind for this reason. It's a bit pity. My son is against it. He's against it, yeah. Well, okay. He's about to decide, and he'll make up his mind together with his companion, with his partner. Thank you. Regarding the carriers, is this true for carriers as well? No, no. I have 2 brothers, carriers, who did this, and this is a very simple procedure, and there was no correction. I don't think that there was any reason for that. I don't think that obstructive azoospermia was the reason for that. It was both my brothers who are carriers. But you'd have to tell us that it is a simple. Yes, it was really simple, and the problem was solved immediately. Off microphone, unfortunately, we can't hear.
Όχι ιδιαίτερη. Δεν υπάρχει κάποια τεκμηρίωση.
There is no scientific documentation regarding carriers on that. I'm reading that some studies say that some carriers might be presenting some symptoms of the disease in their respiratory system. Maybe this could be the case. Well, hello. My question is about cystic fibrosis women who have undergone transplant. What are their hopes of getting pregnant, and would that be recommendable? Yes, it is feasible. They can become pregnant either through assisted reproduction or spontaneously. The problem, well, we had uncharted waters in cystic fibrosis, and imagine what happens with the waters in women following a lung transplant. From my experience in the management of such pregnancies, the problem is the medication. But I heard in the earlier panel that there's medication that is teratogenic, but that may be replaced by some other drug. So if we have a very good preparation early enough, in advance, that is, where is the assisted reproduction coming in? A lady who has undergone transplant cannot stay off medicine for quite some time. So what do we do? We discontinue this, or we have replaced this with another medicine, and we know that she'll become pregnant through assisted reproduction, either through ICSI or IVF. So we get the embryo and we transfer it. And I don't think that this is a utopia for a transplanted woman to give birth. It is feasible, provided that she will want it, because it's strenuous and it's quite risky because she's going to switch medications. But as I said, I think that everyone has a right to maternity, and we're here to support them. Thank you. Thank you. Other questions? Good afternoon. If there's a woman patient and the partner is a carrier, this pre-implantation control, how difficult is it? It's easy, but it is quite costly. It's IVF. Yes, it's IVF. It's IVF. You get the embryo from the first day. So we start checking the embryos. But there are some practical issues. The Greek law prohibits the control, the pre-implantation control, when one is under 40. But in the case of congenital diseases, this is allowed, this is permitted. In the case of a genetic disease, the pre-implantation control is reimbursed for ages under 40. In the case the lady mentioned, 50%. No, it should be 25%. No, one is suffering and one is a carrier. 50% they have a problem. Why am I calculating 75? Yeah, you calculate it again. You'll find the proper result. Miss Anagnosta, I think that it would be really nice to have you here for another hour, but unfortunately time is pressing. Since I saw Mr. Theodoropoulos here and we talked about the transplanted women, and we said that they are uncharted waters vis-a-vis pregnancy, etc. Is there any experience from abroad with women who have undergone transplants and have become pregnant? Yes, I had a personal experience. Unfortunately, there are data, depending on the gender, on the sex of the doctor who keeps track of the pregnancy. We have different results. Obviously, women pulmonologists show greater sensitivity and would recommend to their patients to become pregnant. Definitely 2 years post-transplant are a good period. There are 2 periods in pregnancy where you have a tolerance, etc. There are risks for rejection, and there needs to be a change in the immunosuppressive treatment. It is quite acceptable. Unfortunately, babies are low weight. There is a risk of prematurity. Antibiotics in case of infection is an issue. Yes, but I think that antibiotics are an issue for other women as well. I mean, there is no difference between the transplanted and the non-transplanted patients. However, there are cases who have successfully been able to give birth. Yes, yes. Both pre-transplant and post-transplant. She did well, she gave birth, etc. However, I couldn't have a longer follow-up on her because I've left, it was a year ago. Yeah, I wouldn't discourage anyone. Of course, I wasn't able to attend the whole presentation. The surrogate mother is also an issue. I don't know what the legislative framework is in Greece. Yes. Yes, there is a provision regarding surrogacy, and since there is a genetic problem and there are opinions by doctors according to which women cannot tolerate pregnancy, the next option would be surrogacy. I think that this would be much safer for everyone, for us as well. I think that we do have a patient in Greece who has opted for surrogacy. Yes, she recently addressed herself to us, and we recommended that. But the financial part is an important obstacle. It is important, though, to start having something more organized vis-a-vis the pregnancy, because we'll start seeing pregnancies, and why not in transplanted patients as well. So this is why it's important to have communication and cooperation. Any last question for Ms. Anagnostou? Do you know whether there is a precedent from other diseases where the state would reimburse or cover a percentage of what? A percentage of the IVF, a percentage of the IVF? I don't think so. Aside from what I said regarding the pre-implantation check, a big percentage is covered by the state. I think 75% is covered by the state, is reimbursed. Well, the fact that you're going to have the IVF, well, means that you have the medication, the drugs, etc. Unless you do it on public body. In the private sector, it is what the prices are for everyone, with the exception of the pre-implantation test. What about this procedure for men to get the spermatozoa, etc.? Is this reimbursed by the state? Can this procedure take place in a public hospital? In theory, yes. But I think that it has to do with the organization. Yeah, it could be organized. Okay, thank you very much. Very interesting.
We will invite you again, but those of you who have more questions, you can meet her after the end of the conference. Let us go on to the next speaker, Mrs. Kousta Ekaterini, postgraduate physiotherapist at Papanikolaou Hospital in Thessaloniki. She will be with us online. Oh, we already have her. Welcome. Good afternoon. Thank you very much for the invitation. Sorry for the waiting. No problem. that everybody has to be functional because coughing and expectoration create a malfunctioning. So respiratory physiotherapy provides the solution for functionality and for a good daily routine. The aims of physiotherapy generally is improving pulmonary aeration, bronchial clearance, increase of reduced respiratory capacity, mobilization, and respiratory restoration. As you see, the goals of physiotherapy are the same as with normal people, as with non-cystic fibrosis people. Λοιπόν, first, body positioning, Fowler's position, breathing, active respiratory circle, exercise for breathing control, or independent drainage, forced expiration, positive pressure in air ducts, bronchial drainage with gravity and manipulation, and exercise of muscles. Autogenous drainage. Most patients do respiratory physiotherapy lifelong. So they have normal breaths executed in different levels, 3 seconds pause, and mobilization of secretions with airflow at expiration. In 2007, when I had my physiotherapy conference, or rather, prior to 2007, I'm sorry, but I don't have a good connection. There seems to have been a different approach in the past. Now they are trying to remove secretions with airflow. We don't want to combine physiotherapy with breathing fatigue. Patients should eliminate their secretions with no effort so that they can repeat these movements during the day. This is the active breathing circle. You can read it. We use cough when needed. This is sputum that arrives at your throat and you are ready to take it out. This is when you cough. Breathing control. Breathing control is a normal, calm breathing at the lower part of the thorax by relaxation of the upper level muscles. Expiration with half-closed lips. These techniques, the last two, can be used in case of dyspnea or feeling of not being able to breathe. The half-closed lips reduces the number of breaths and creates relaxation. Whether the previous things that I described was for expectoration. Forced expiration on various levels can mobilize secretions. During the technique, there is compression of the walls of the air ducts in the direction of airflow. This is to be used as a last resort when we feel that sputum is at our throat and it cannot go out. Forced expiration is never used when there is blood in the sputum. Bronchial drainage with gravity and manipulations. There are 6 to 12 positions and gravity is used to move the mucus from small to big air ducts. The patient is placed in a lateral position. I have a very nice video, all the techniques together. Then we have positive pressure devices, the a cappella, flutter, and cornet. Flatten is the most frequently used one because they can wash it, rinse it. And also when patients become of age, they may be tired and bored with respiratory physiotherapy. These devices are easy to use, they are perhaps more pleasant, and they give more options to patients. Or they can have a combination of physiotherapy and devices, or they can use the devices when they go on a trip, on an excursion, in order to expectorate without getting tired. Can you play the second video, please? This is the flutter. And now we cannot tell what the speaker is saying. Physiotherapy. When? Why? Is it associated with pharmaceutical treatment? Is it associated with exercise? These are some of the questions that we can answer. Perhaps you can answer them. I will say a few things and then we can discuss them together. Okay, when? It starts as soon as the diagnosis and continues to the end of the patient's life. Why? In order for expectoration and for good respiratory function. What is the association with drugs? Should one precede the other? Usually the patient does the therapy, takes the treatment, waits for 20 minutes, does the physiotherapy, and then uses the inhaled antibiotics. Why because inhaled antibiotics have to enter a clean lung. There is a lot of literature, this is by way of indication, on the relationship between exercise and physiotherapy. I have always believed that we should first do respiratory physiotherapy and then exercise, because exercise will be facilitated in that way. Most patients don't want to do respiratory physiotherapy. They are tired. I understand them. They have to go through that year after year. So they don't want to do physiotherapy and they replace it with exercise. This is a mistake. They are totally different things. First, you have to do respiratory physiotherapy, eliminate the secretions, clear the lungs, and then you do the exercise. And if there is more sputum afterwards, so much the better. You eliminate that as well. Thank you very much. Any questions? Question. Well, I can wait for questions later. I don't mind. Thank you. There are no questions. So we move on with the next speaker.
Ms. Rakidzi Stavroula. Big thanks to Ms. Rakidzi, who is a volunteer psychologist and who has undertaken voluntarily the psychological support program run by the association in the past 2 years with very good results. She's going to present this to you, and we thank her for her volunteering for our patients. I'm the last one, so I'll try to be really, really brief. Volunteering in mental health experts is something that is self-evident. You don't need to thank me. This action is devoted and dedicated to all the members of the association and in memory of little Nicolas. We have stress disorders, depression, and fear of death in cystic fibrosis. Fear of death is not a mental disorder, but rather an existential reaction against something which is really difficult. So all scientists who have come here today before me and psychotherapy aim at reducing your vulnerability and at rendering you much more resilient vis-a-vis stress. The ultimate goal of psychotherapy is recovery and rehabilitation on the basis of the realistic data for each individual. There are two personal viewpoints. The recovery is a result. We measure the efficacy of our therapies, and the recovery as a procedure. You yourselves, you evaluate at all times, on a daily basis, on a monthly basis, on a yearly basis, your own course. And since you are the protagonists and not we scientists are obliged to help you and simply support you in the absence of the state. which does not support the health systems. So since you are the protagonists, I've called upon the members of these teams. I'd like to welcome Marilena here with her son. Stella with her family. Yannis with the entire family. And Miss Athena, a grandmother who urgently came for the conference and who is really in a hurry to leave. So, cognitive behavioral psychotherapy is an effective therapy. There are many studies, and it examines the interaction between feeling, behavior, and thoughts. So we offer a group therapy that consists of 13 weekly 1-hour sessions. We have as a main goal to reduce the stress, to improve the mood, to empower and enhance skills, and we have an introduction into the management of grief. So we want to collect a sample in the coming years and be able to present to you a much more reliable result. But gradually we start seeing results. So we give questionnaires before and after. The patients group consisted of 14 members. 4 discontinued, 10 continued. The reasons of discontinuation: 3 were stressed, 1 declared that they were going to participate but never came. Group therapy is difficult, particularly when you have to be exposed online. Now, in the carers group, we had 16 members, 10 discontinued. There was a great difficulty by the carers to adjust to the rules of the team and commit for 13 sessions. We'll always be there, available, so those of you who want, you can come. So in fact, we have 6 members who completed and 5 who has sent questionnaires. So therefore, our samples are really small. Regarding the patients group, they have statistically significant results in stress reduction, in their ability to say no and place limits, recovery, and in the ability to do things that fill them with pleasure, as well as in their functionality. It is important in 13 sessions to be able to improve the functionality of patients. Also, it is quite usual for us social scientists to also check the effect sizes. The effect size is about how much psychotherapy has an impact on the several variables, and we have high effect sizes and an overall indicator of effectiveness, total therapy effect 0.57. In the carers group, we have a very small sample. However, we do have statistically significant results vis-a-vis depression and their ability to say no. And the effect sizes, well, moderate to high at all variables: depression, anger, functionality, etc. And total therapy effect 0.48, a very good one. Now, all these above results are correlated with a pilot implementation of 2022 and with international studies. Some of these persons were referred for individual psychotherapy because we are talking about an aggravation for many, the burden being too significant for many people. So then I referred them to the national health system, and these persons presented improvement. The aim of this intervention is training and education in managing a mechanism to deal with the daily life and to reframe life in order to enhance and strengthen individual responsibility, not only vis-a-vis the pharmacotherapy, the diets, etc., but also in the mental strengthening. The disadvantage of this specific year was that there was a big dropout of the carers and there was no comparison with a control group. I myself volunteer, but if we want to have a comparison with a control group, we need to find 2 more psychotherapists, volunteers. So psychotherapy is an indispensable part in the management of cystic fibrosis. We'll go on, and in parallel, I also ask the members, statistical analysis is our own job, and it is an objective data in order for doctors to understand how effective the treatment is. So the pediatricians say, okay, I'll send the parent to a group therapy. But what is also important is the impression of the members. So they told me I can think alternatively, I can be able to manage negative thoughts, I manage stress, anger. I improved empathy. We're not on our own. We are a family. This is the most important thing. If there's something that we stand to gain from these themes, is participation and this feeling of family. You do not feel ashamed to ask for help. You come to the groups, you commit for the sessions, and you ask for help. It is not a shame. Those who are burdened by health problems to have some mental burden. Thank you very much, and I will continue. I'll start with the cares because our dear Miss Athena, our granny, needs immediately. So you have the floor, Miss Athena. Good afternoon. So today I'm standing here. I've heard very optimistic messages from the experts that filled me with hope and relief. Now, we live as a family together with cystic fibrosis, that I got to know as a disease, with my grandchild, who is 2.5 years old today. As soon as we heard about the disease, I had negative feelings, fear, concern, insecurity, stress, all these negative feelings. It was darkness. Misinformation in the social media was horrendous. This was the first access I had. Trying to find some light, I got led to the association. It was a relief because I felt that I belonged to a broader family with the true meaning of the term family. I received messages and they allowed me to see some light. Then the association organized the psychological support sessions in which I stated that I would participate, and indeed it was really important to get all this help as a mother and such a short notice from coming in contact with this disease. The framework was extremely supportive. Now, I think that this is different from psychological supports on an individual basis with a psychotherapist. I've experienced the group psychotherapy, and this allowed me to share, to listen what other fellow carers had been going through, and this gave me strength and courage. I think that it is really important for us as an association to try to go on with these group therapies because they're really helpful for members. I can vouch for that personally because together with all the therapeutic ways and methods, it's also this part. When you're on your own, we live in the countryside, and it is important for us, and it plays a therapeutic part to be part of such an effort. We do need that, and we thank you for whatever you have offered us so far, and I hope that we'll be able to have it also in the future, and if possible, I hope that it will be reimbursed and be provided by the state if we are to have such a support as carers. Not only for carers, but also for patients and for our own child who is 2.5 years old and still hasn't understood what it suffers from. Miss Athena, just tell us a few words about the future because we don't have time, so others need to speak. Tell us what you think of the future. What I expect from the future is to have our young patient enter the triple combination therapy, to have as many procedures in Greece as possible. What we hear about gene therapy is what fills us with hope and allows us to see some light in the thoughts that come and go all the time. Thank you. Thank you.
Γιάννη, σειρά σου.
Yannis, it's your turn.
Good evening. I am John Veloudis. I'm husband to Anna, a cystic fibrosis patient. She's 42 years old. And we are very happy for that because when you talk with someone, people hide years or don't accept the growing older. But in the case of a cystic fibrosis person, things are different. It is something happy. It is a victory to terminate another turn around the sun. But the truth is that nothing is given, and this is true for everybody, not just for patients. 3 years ago, Anna and I were almost permanently residing in Sysmanoglu Hospital. Her health was very poor. She had to do IV treatments very often. At that time, there was this revolutionary treatment that freezes the tree kafter. We lived this with many struggles. The Hellenic Association on Cystic Fibrosis managed to bring this drug to Greece, and almost in 1 year, perhaps less, when according to the normal prospects as a new and expensive drug, were 5 or 6 years before it would come to Greece. That was a very big victory. Now, for the association and the struggle, the battle they waged and still wage, we should not forget whom it is comprised of. It is cystic fibrosis patients who work pro bono with a lot of cost for their health and a lot of time dedicated to that. I've always been around the board, and I know nothing is given. And this new treatment helped us to leave the hospital behind and come back to our lives. Anna is going for walks, she's driving a car, she goes traveling, she swims in the summer, and she makes plans for the future. It seems that with the strength of science, cystic fibrosis is beginning to lose ground. I feel confident that it will only become a medical history in the future, a medical history that was healed. Unfortunately, not all of our friends had the opportunity to take the new drug. We will always remember them. We just want to live many years in order to remember them. We will remember them fondly. In concluding, what I'd like us to keep in mind is that with patience, reason, and confidence and trust in medicine, everything is possible. Be strong, because the best is yet to come. Thank you.
Συγγνώμη λίγο. Κάτσε. Και επειδή το θαύμα της επιστήμης...
The miracle of science is in front of you, Join, the husband of Anna.
Εγώ θέλω να πω ένα μεγάλο...
I'd like to thank Yannis personally, Yannis, John. We went through some difficult times. I wouldn't be alive unless I took this drug. I lived, and many others lived, and John has been next to me from the beginning to the end, and I'd like to thank him.
Κάποιοι από εσάς νιώθετε συγκίνηση.
Some of you feel emotional, but this is cystic fibrosis. There are many feelings involved. And now the floor goes to the patient. I have two historical figures. Stella, the relay goes to you. Stella's artwork is in Gianni Nosocomio. I hope you will always be healthy, Stella. 38 years old. I have been a patient for 36 years. I've gone through many stages. The first stages when it was considered an incurable disease. We were waiting for a drug. My doctor used to tell me it's coming, and it was not coming, and things like that. I didn't have time for the innovative treatments when they came around. When I was 18 years old, I had my first transplant in 2006. It didn't go well. I did a second transplant in 2014. Luckily, I am in a very good condition now. I can do things. I can do the things that I wasn't able to do when I was worse in the past. I'm now studying, I can keep fit. I feel very different now. Of course, transplant is not a panacea. It opens new doors, it opens new horizons, but the problems are many and you have to be monitored. I can say that we are countering statistics which speak about 10 years of life expectancy. It is much more. I am transplanted since 2006. I'm 40 years old now, and I have more time in front of me. The question is, you need to have a will to live. But this is true even for those who are not patients. Everybody needs to be optimistic. We should not give up. Nobody should give up. Everybody should fight for the best, do things for themselves. My psychotherapy with Mrs. Rakirji was very helpful. She taught us to claim things that when I was in a poor condition, I didn't have the strength to claim, to fight for. I wasn't feeling self-confident. I wasn't believing in myself. I didn't have any self-esteem. This is a problem that you often find. In general, the association all these years has done a very constructive journey with the patients themselves. I believe that in Greece there are many things that can become better, a better organization with doctors, with centers, a better structured situation to avoid going from one doctor to the other and have everything put together at one place, and hopefully to have a treatment that will be appropriate for us who transplanted, to solve not only the respiratory problems, but also the pancreatic problems and all the rest. Because in essence, we don't have only the cystic fibrosis problems, but we have the problems that are due to the transplant medication. Thank you.
Marilena, it's to you to whom we pass the torch. Good afternoon, everyone. A big thanks to our Stavroula, who psychologically supports us with her ever present interest, with many thanks to the doctors and to the nurses. Let me say a few words about me. My name is Marilena. I'm 56 years old and more, and I feel like all those women who many years ago had a predefined future where their parents would oblige them to marry someone. So this is how I saw cystic fibrosis. But to me, this was not a yoke, but rather a partner. I wasn't suppressed by it and oppressed, and it gave me incentives to do things that a patient with cystic fibrosis would never do. Most of the things I wanted to do have been done. There are other things in the list to keep on having incentives for the future. But what I want to say is that I had definitely been through many obstacles in my life, which I overcame thanks to my courage and stamina. I saw them as a challenge. I'd like to share with everyone that you need to look at the future with optimism, claim your rights, and do away with the selfishness. This is really erosive. I have nothing else to say. Keep the faith, have trust in yourself. Most things can become true and a reality. And I'd also like to call upon my son as proof that things can happen. It can become a reality. He's 27 years old, so everything can happen. Anything can happen. Concluding, I'd like to thank you These four people said just one thing. The best way to deal with the fear of death is action for life. We all die. We all are born and die. We can't get away from death. But for some people, death is more specific. With the new treatments, cystic fibrosis, in cystic fibrosis, life is extended. So keep on living, keep on demonstrating this strength for life. Be well. Now, I saw that Marilena, Stella, etc. Marilena was the first patient in Greece, a patient with cystic fibrosis who became a mother, and she was the first president in our association. It was back then, in 2000, the first time that we had adult patients in the board of the association. We've been through Stella. Stella has a first here. She is the first female patient in Greece who has undergone 2 lung transplants, and she is amongst us. She will continue to be amongst us for many, many years. I'd like to thank Stavroula Rakinzi for everything that she has offered. Indeed, we really needed the psychological support because we had left this behind. We were dealing with the medications, the treatment, etc. And we would forget about the basis of everything, mental health. Where are we to go with our mental health? So this was a big offer by Stavroula, and we're really glad that we're going to continue next year. And let me announce it that we are going to continue as of January. We'll have our new groups, carers and patients, as of January. So very soon you get the news as to when we will start, so that you can all participate and enjoy this big gift by Ms. Rakinzi. Konstantina, would you like to say something? I don't know, I'm really touched. I'm really emotional. There is always hope. This is what we keep. And all the testimonials of our friends show exactly this, that there's always hope, that anything can be done. And I will wish us all health. And a big thanks to my mother and my father for all these things that they have done for us. So we will conclude with this session. Thank you very much, Ms. Anagnostou, for having come from Thessaloniki next to us. I think that many of us patients will come to you, and we will have you next time. Ms. Rakinzi, thank you warmly for having come here, supporting our association. We thank the patients and the carers.